Our next speaker is Dr. Aneesh Singhal from Massachusetts Harvard School and Boston, and he will be joining us at 4:10.
Yeah, good afternoon, ladies and gentlemen. We are fortunate to have Dr. Aneesh Singhal with us. He has already joined us. Professor Aneesh Singhal is a great son of the soil. He is professor of neurology at Massachusetts General Hospital, Harvard Medical School, Harvard University, Boston, USA. Professor Singhal has very keen interest in stroke, particularly RCVS. I welcome Professor Singhal and I thank him for sparing time to deliver his talk on RCVS. Thank you. Thank you, Professor Singhal. And we are indeed grateful to you for joining this Stroke Conclave 2022.
Well, good evening to all of you. It is a real privilege, and thank you, Dr. Suresh, for inviting me. I hope all of you have had a very good session. I think I really like the agenda that Dr. Suresh has put together, starting off with the stroke quiz and anti-thrombotics and antiplatelets, venous thrombosis, just fantastic. He asked me to speak on a topic that would be relevant to all of you. And I thought, even though I've spoken on RCVS before, and I apologize if many of you have heard me speak before, I think it is quite common in my experience, but for some reason, it doesn't seem to be as common in India. And I think a lot of cases are going unrecognized. And once they are recognized, it's possible that they're not being managed properly. So I thought this would be a good topic to repeat, or at least if you have not heard it, you may enjoy listening to it for the first time. So let me just go to my slides and try and share them. Give me 1 second. There you go. Okay, thank you. So I'm assuming you can also, yeah, I can see the picture in picture. So here you are. So RCVS, and thank you for the kind introduction. These are my disclosures. I think I do want you all to acknowledge that there are medical legal cases when RCVS is misdiagnosed or treated inappropriately. Today, I'll share with you how to accurately diagnose this condition and how to manage them, especially in the intensive care setting. So what is RCVS, or the reversible cerebral vasoconstriction syndrome? This is a term that I coined in probably 2002 as CVS, and then we wanted to emphasize the R. So in 2007, we called it RCVS. It's a group of conditions, okay? It's reversible. The main angiographic hallmark is segmental narrowing and dilatation of the intracranial circle of villus arteries and their branches. And of course, the vasoconstriction also affects the distal arteries, but angiographically, that is the hallmark. It affects women 4 times more commonly as men. Consistently, the mean age in various studies is around 42 years. The cardinal presentation is sudden onset of explosive 10 by 10 pain in the head. Now, about 10% of patients don't report this either because they can't remember it or for some other reason, like they've got a brain bleed or something else. Now, the imaging hallmark is a normal scan with the repeat thunderclap headache becoming abnormal. So that conversion from normal to abnormal is the hallmark. 60-70% have a normal scan throughout, but about 30% can develop complications such as brain hemorrhage, convexity subarachnoid hemorrhage, infarcts, or press-like lesions of brain edema. And I know that the following talk is management of brain edema. Now, the most important thing for you to remember, it's a self-limited condition with largely benign outcome. Even if people get strokes, the outcome of those types of strokes are better than other types of strokes. Now, angiographic reversal almost always occurs. In about 2% of patients, it does not occur. No specific treatment is needed except symptomatic treatment. And long-term patients do well, but they do report headache and depression. mostly because previous to the onset of RCVS, they also had headache and depression. Now, I'm seeing a case every 3 weeks, and I've been doing so for the past 20 years. But the question is, when I ask my colleagues in India, they're not seeing it as often. So why is that? Is it a ethnic difference, racial difference, or is it something else like clinical recognition? And I suspect it's more likely the latter. Population studies have also shown a relatively high frequency. And the more and more studies are coming out because we now have a diagnostic code for RCVS, so they're able to interrogate it. Now, if you're talking about the acute setting, which is today's conclave, thunderclap headache, or many patients come into the emergency department with sudden onset of bad headache. You typically think of subarachnoid hemorrhage, but now start considering RCVS if the patient has recurrent thunderclap headache. Okay, that's the main message for many of you today. So what is RCVS? This is one of the first cases I saw 20 years ago. 46-year-old man with this during sexual intercourse, explosive headache. Everything was normal, although all of us thought this must be subarachnoid hemorrhage. Then we saw this arterial narrowing, segmental arterial narrowing and dilatation. You might argue that this segment is a bit more dilated. So what was this? We didn't know. We thought it could be vasculitis, could be cryptic subarachnoid hemorrhage. But he kept having bad headaches, developed some Balint syndrome, cortical blindness. MRI showed developing infarcts. We didn't know what it was, so we just watched and really let nature take its course, gave him symptomatic treatment for pain. And over the next 2 weeks, 3 weeks, his blindness resolved, the transcranial Doppler flow velocities normalized, and the MR angiogram showed reversal of vasoconstriction. So this is the typical scenario. Recurrent 10 by 10 headaches, visual symptoms, strokes, and then recovery. When I started investigating this, it was like an elephant in the room, with various parts being labeled differently in the literature. Turns out that different labels in the literature included all of those listed on this slide. Drug-induced, migraine angiitis, benign angiopathy. My major contribution was to recognize that these were all nomenclatures with of the same syndrome, with the same clinical imaging findings. And I put this together as a benign condition that is not vasculitic. This is not an angiitis. Okay, this is an angiopathy or a vasoconstrictive phenomenon. And then we looked through the literature and put together a list of triggers or precipitating triggers that had been identified by clinicians when they reported these cases. So most patients did have a prior history of headache disorders, drugs and medications, exposure to hormones or tumors, but about 30% there was no identifiable trigger. So keep that in mind. Now, the point of this slide is to show you the spectrum of potential triggers. Again, this is hypothesis generating. We don't know if this is true, if there's a cause and effect, but there's clearly a very strong association because across the board, in various studies, we found the same kind of recent exposures. And everything listed here has a vasoconstrictive effect, including nicotine patches, licorice, which we have mahuang, pregnancy, the changing hormonal levels have something to do with it. So keep this in mind as you take the history in a patient with bad sudden onset headache, especially recurrent headache. Individuals don't often reveal that they've taken mahuang or they've had some marijuana, for example, but it's rather common. Ask them about over-the-counter medicines. And in India, I don't know the role of herbal medicines and Ayurvedic medicines or homeopathic medicines, so we just don't know. But it's important to keep a document and record and ask for the history. Okay, so that's the first step in history taking. Doesn't matter if it's drugs or pregnancy or something else, probably not. I did a study comparing these three classes of triggers and really didn't find anything different between the subgroups. What about the gender differences? We did explore them. Turns out that men, as compared to women, are on average, when they're affected, about 15 years younger, which is curious. Women could be Hispanic, but I've seen only one man who's Hispanic to date. This is an outdated slide now. And you can see that there's a difference in the exposures as well. Migraine, depression, and so on are much more common in women. And then clinical worsening, more common in women, typically pregnant women. So that's something to note. Now, historically, since vasculitis was first described in the early 1950s, patients with RCVS were being treated as if they had vasculitis empirically. The main point here is that this is a vasoconstrictive, it's a chemical phenomenon, it's not inflammation. And we've done autopsy studies. This is a case published in the New England Journal of Medicine, where there was really nothing in the arteries, brain and systemic, to suggest inflammation. All we saw was this sort of more pleating in the elastic lamina, suggesting a vasoconstrictive process. What we've also done is natural history studies, and we found that there's a difference in the time course of complications. For example, brain hemorrhages tend to occur much earlier, parenchymal or convexity. But then strokes, because ischemic stroke, because of the vasoconstriction moving more proximally, tend to occur a few days later, by about day 7 or so. So keep that in mind as well. So you're on the ICU in the acute setting, bad headache, initial scan normal, another bad headache, it could signal the development of a bleed, okay? And then later on, you might expect strokes. This slide is important in terms of how long to monitor such patients, okay? So the patient comes in already with convexity subarachnoid hemorrhage, you may not need to monitor them too long. But if they're not yet, then maybe you should monitor them longer, just as a suggestion. What we've also learned is the spectrum of RCVS is expanding. Some patients can come in with isolated thunderclap headache, benign thunderclap headache, which is a primary headache disorder. It turns out that if you image patients with just a bad headache and no secondary cause, their vessels may show abnormalities. In that case, we classify them as RCVS. If you image the brain and they have brain edema, we call them PRES. So there's a lot of overlap between these three conditions, between RCVS, PRES, and thunderclap headache, suggesting that there's a shared underlying pathophysiology. Some patients with RCVS or thunderclap headache can come in with sudden memory loss, identical to transient global amnesia. In a minority of cases, the heart, and you may want to do echoes in your patients, can show reversible cardiomyopathy, identical to Takotsubo. And at Mass General, we've seen curiously about a dozen patients who also had concurrent, what appears like spontaneous carotid artery dissection, SCAD. But really, I suspect that they have vasoconstriction, at least some of them, concomitant with the cerebral vasoconstriction. So the spectrum is expanding. None of us really know why this happens all of a sudden at age, let's say 42 in a woman. But we do think that there's an overlap with the primary thunderclap headache. And we think the raphe nuclei with the projection onto the surface of these brain arteries have something to do with it. And they may have more serotonin release onto these arteries, causing them to have segmental vasoconstriction. The same serotonergic abnormality can also culminate in endothelial dysfunction. We have also shown that there's SFLT1 endoglin abnormalities. Others have implicated serotonergic receptor polymorphism. So we don't really know, but these are all hypotheses. And on this slide, there are a list of references showing you how variable we are in our thinking at this point. It's also possible that there's an underlying connective tissue disorder. As we've done, we did a study comparing RCVS to vasculitis or primary angiitis against controls and found that patients with RCVS more often had unruptured brain aneurysms, unruptured, and that's a cause of confusion because you're seeing convexity subarachnoid hemorrhage and an aneurysm, but we have to be careful to implicate a surface bleed with a brain aneurysm. Surface bleeds are rarely because of a brain aneurysm, almost never. Okay, the brain aneurysms, when they rupture, they cause Sylvian Fisher bleeds or basal cistern bleeds. So these increased frequencies suggest that there may still be an ultrastructural connective tissue abnormality. So how do you manage such a patient? Let's say you're in the emergency department or in the ICU, patient with bad headache, normal scan or a bit of convexal subarachnoid hemorrhage. The first thing to do is to rule out mimics, okay, secondary causes of bad thunderclap headache, aneurysmal bleeds, okay, is it a brain hemorrhage, venous clot, dissection of the carotid vertebral arteries, pituitary apoplexy, and certain kinds of encephalitides. A normal brain scan typically rules out all of the above. So you should do careful brain and vascular imaging in any patient with suspected with onset of thunderclap headache. My colleague over at Beth Israel, Dr. Jonathan, he's come up with this algorithm, which is published in the emergency department journals. I think it's very good. Step 1, brain CT. If you see something abnormal, that's the diagnosis. But if it's normal, then consider a lumbar puncture, unless the patient has multiple thunderclap headaches. Multiple thunderclap headaches are only RCVS. I don't think there's any other condition where you get 3, 4, 5 thunderclap headache. Okay? So that you can proceed with CTA, and if it's diagnostic, your workup stops. If the patient has a single thunderclap headache and a negative CT, I think we're obligated to do a lumbar puncture. We could diagnose subarachnoid hemorrhage or other conditions. The LP is normal, then stop. Okay, then just wait and see if the patient resolves. It could be a benign primary isolated thunderclap headache. So I think this is a very good algorithm. How do you distinguish RCVS-related convexity bleeds, which are common 30% of the time in patients with RCVS, versus aneurysmal rupture? So we looked at this. We don't have a scoring system, but patients with RCVS-related convexity subarachnoid hemorrhage are different. They're younger. They have a history of a prior headache disorder, depression, and COPD. On brain scan and clinical imaging and clinical findings, the Hunt-Hess grade is less. The Fisher group is much lower. Fisher group is usually 1 or 2, unlike aneurysmal bleeds where you get Fisher 3, 4. Okay. What about vasculitis? As I said, there's been a history of labeling patients with RCVS as having vasculitis. And consequently, patients with RCVS have been subjected to brain biopsy, empiric treatment with glucocorticoids. But really, we now know that these two conditions are quite different in terms of the character of the headache, the watershed, typical watershed location of strokes if they happen, the lobar hemorrhages and cortical convexity subarachnoid hemorrhages are very common in RCVS, extremely rare in PSCNS. There are lesions that I think are very different if you examine the brain scan carefully. Normal in many patients of RCVS. These are the watershed infarcts I told you about. As I said, you can get press and hemorrhages, which is very rare in PSCNS, as depicted on the following slide, where you see you get strokes, but look at these. These are the strokes of vasculitis. This is very different from these types of strokes of RCVS. So I think careful history taking and very careful understanding of the imaging abnormalities, as shown in this slide. By the way, this was published in Annals of Neurology. You all can read it at your leisure. So I think based upon all of this, we realize that there's a difference between RCVS and other vasculitis or arteriopathies such as moya-moya, premature atherosclerosis, or systemic or infections, radiation. So we did a study comparing RCVS with all of the other angiographic entities in the brain. We came up with this scoring system, which has stood the test of time. Published in 2019. Over the past 3 years, I've been looking at the score in all cases of RCVS, and it's very accurate. RCVS is an acronym standing for recurrent thunderclap headache, carotid artery affliction. If it's there, the top of the carotid, that's not affected in RCVS. If the top of the carotid is narrow, think of moya-moya. V is for vasoconstrictive trigger, and the 2 S's are for sex and convexity subarachnoid hemorrhage. This is available on mdcalc.com, and if you do it, you can see that the diagnostic accuracy approaches 100%. I don't think any other test is going to beat this very simple bedside scoring system based upon history and the admission imaging finding, That's it. You don't need any more testing. You don't need LP, you don't need angiogram, you don't need anything. Okay. So what's the implication? It gives you an accurate diagnosis upon admission. You don't need any diagnostic tests such as injection of vasodilator. It's a bad idea. You shouldn't do it for diagnostic purposes. And moreover, you don't even need to keep repeating scans because this is a benign entity. It's going to get better. My colleagues have started looking at advanced MRI to distinguish this RCVS from other entities. I think there's potential, but honestly, you can never approach a 99% accuracy as with the score. You can do this, but I don't think it's helping me because I can make the diagnosis quite easily. I'm going to end in the last couple of minutes with management. If you remember this slide, apart from the score, I think that's enough, okay, as a take-home message. Symptomatic treatment is all that's needed. Basically, take away the trigger if you identify it. Avoid doing anything that the patient is going to get better. Specifically, avoid exposing them to steroids. Don't send them for angioplasty, intra-arterial manipulation, unless you're watching and the patient has consistent clinical deterioration. This slide shows you that if you give steroids, okay, these are the steroid-exposed patients, and here's the event. Much worse with steroids as compared to without steroids. So the point is, don't try and cover your bases by giving steroids in case the patient has vasculitis. Use the scoring system and be confident that you made the right diagnosis. Intra-arterial vasodilators are being advocated by some centers as a diagnostic test. Bad idea. You don't have to take a young patient, healthy patient, and insert a catheter and poke, put contrast to make this diagnosis. It cannot be justified. This is what can happen. This is the patient who came in. She was doing well. She had significant arterial narrowing. Unfortunately, they took her for intra-arterial nicardipine injection. Great angiographic resolution. Look at this. This is the pre, this is the post. But ultimately, because of reperfusion, you can get significant damage. This patient went to the morgue. She developed a lot of reperfusion injury, hemorrhages, although she was doing well initially. So angiograms can be problematic. So to summarize, it can be easily diagnosed based upon a careful history and a review of imaging. You can use the score. Exposure to prior meds is an important part of history taking. Those meds should be avoided. Angiograms, empiric steroids, avoid. Don't try and do any intra-arterial diagnosis. Follow-up scans are also not needed. Now, recurrence of this syndrome is exceptional. Some studies say 5%, but they're talking about recurrence of just an isolated thunderclap headache. A full-blown syndrome with brain hemorrhages, etc., it just doesn't happen. Avoid vasoconstrictors for the long term if possible, but if clinically indicated, you can still re-expose them to serotonergic antidepressants, for example, and I haven't seen any bad outcome after that. If the patient gets pregnant in the future, monitor closely for eclampsia because that could be an issue. And just treat them for long-term depression, headache if that occurs, and mainly reassure the patient that nothing bad is going to happen. So I'm very grateful to Dr. C. Miller Fisher, Lou Kaplan, and the colleagues from Cleveland Clinic, Brazil, Turkey, and of course my parents and family for assisting me and tolerating me as I conducted this research. So thank you very much. I'll stop the share and be open for questions.
I must thank Professor Aneesh Singhal for a very masterly talk on RCVS, which if it is he's seeing 15 to 20 cases per year, it's a large volume. I'm very grateful to him because I think he's brought this topic close to our heart and to our mind so that we can also pick up these cases much better. I'm sure we must be having our share of cases also, which may not be picking up. So is there any question, short, 2 or 3, fast? Anybody else wants to ask a question to Professor Aneesh, please?
I suspect many of these patients are being admitted as brain bleeds from a ruptured brain aneurysm. So I think it's important to distinguish those two, or they're being treated as vasculitis. So if you all can keep this entity in mind and avoid these common pitfalls, that'll be a big win for everybody.
Thank you very much, Dr. Singhal. It was a real very nice talk. Where you rightly discussed everything regarding this condition. Thank you very much. Once again.
Okay, all the best. I'm delighted to see the participation from the audience. Great audience. Thank you and good luck.
Thank you, sir.
Now I would invite Dr. Suresh Gupta sir to present a bouquet to the chairperson.
Before I present bouquet to chairpersons, because there was a confusion about tea, so we couldn't introduce chairpersons to you. Chairpersons for this session were Professor Dhanpat Kocher. He was professor and head of medicine neurology at Sardar Patel Medical College, Bikaner, and Lieutenant General Professor K.K. Singh is a senior consultant and advisor in Santokhadulaji Memorial Hospital. So I take this opportunity to honor them